Welcome to Pulse&Pressors, where critical care gets crystal clear. Preload and afterload are not academic concepts. They are the two forces that determine stroke volume, cardiac output, perfusion, and survival. Every shock state, every vasoactive drug, and every hemodynamic intervention interacts with these forces. Misinterpreting them is one of the most common and costly errors in critical care. Preload is not fluids. It is myocardial sarcomere stretch at end diastole. We use left ventricular end diastolic volume or pressure as a surrogate, but preload is fundamentally a biomechanical state. Venous return, thoracic pressure, and right ventricular function determine how much blood reaches the left ventricle to stretch those sarcomeres. Afterload is the wall stress the LV must overcome to eject blood. We often use systemic vascular resistance, but true afterload is a combination of aortic impedance, arterial compliance, and left ventricular geometry. A hypertrophied ventricle with small radius tolerates afterload better than a dilated, thin-walled one. The vascular system sets the stage. Stressed volume and venous tone determine preload, while arterial tone and compliance dictate afterload. Ventricular arterial coupling, the relationship between ventricular elastance and arterial elastance, determines whether a heart operates efficiently or struggles. Pressure-volume loops reveal everything. Preload increases shift the loop rightward. Afterload increases elevate the upper left intersection point and shrink stroke volume. In shock, these loops distort, collapse, or shift depending on the dominant pathophysiology. When preload falls, venous return is inadequate, the right ventricle underfills, and the left ventricle becomes small and hyperdynamic. Hypovolemia, hemorrhage, or impaired RV function all produce the same physiologic fingerprint. The passive leg raise is the cleanest way to test preload recruitability in real time. When afterload falls, the vascular system loses tone. This is Vasoplegia, characteristic of sepsis, severe anaphylaxis, or spinal shock. Stroke volume may be normal or high, but MAP collapses because systemic vascular resistance is critically low. This is afterload failure, not preload failure. When afterload rises excessively, stroke volume plummets. Aortic stenosis, severe hypertension, or excessive vasopressor dosing force the left ventricle to push against high pressure. In these states, the heart is not empty. It is trapped behind a pressure wall. Echo reveals preload states instantly. A small left ventricle, underfilled right ventricle, and collapsible IVC suggest low preload, but the gold standard is dynamic. Velocity time integral, or VTI, increase during passive leg raise. Static measures mislead. Dynamic measures tell the truth. Echo clues for afterload are more subtle. A small left ventricle cavity operating at high pressure with minimal variation in filling suggests high afterload. Hypertrophy, or a narrow left ventricular outflow tract jet at high velocity points toward pressure overload. A left ventricle that doesn't dilate with passive leg raise indicates afterload, not preload limitation. Preload optimization requires physiologic discipline. Fluids are given only when stroke volume increases. A flat response to passive leg raise signals that fluids will worsen congestion without improving perfusion. Expert clinicians treat preload as a dynamic variable, not a fluid prescription. Afterload optimization is equally precise. Low afterload requires vasopressors, usually norepinephrine. High afterload requires vasodilators, such as nitroglycerin or nitroprusside. The goal is to restore ideal ventricular arterial coupling, the point where the heart produces maximal forward flow with minimal oxygen cost. True hemodynamic mastery lies in coupling. A ventricle that is poorly matched to arterial load becomes inefficient. Shock states severely uncouple the system. Proper therapy recouples them, restoring hemodynamic harmony. Pathologic patterns include preload failure, pure afterload failure, and mixed patterns. RV-specific preload failure is especially dangerous. The RV collapses under small decreases in preload or small increases in afterload. The RV operates under an entirely different physiologic regime. It is exquisitely preload sensitive and catastrophically afterload sensitive. PE, hypoxia, acidosis, and hyperinflation destroy RV function. Treating the RV with LV-based logic leads to rapid deterioration. Pharmacology modifies hemodynamics through preload and afterload. Norepinephrine restores afterload. Dobutamine boosts contractility and reduces afterload. Nitroglycerin unloads the left ventricle. Phenylephrine increases afterload dangerously in left ventricular failure. The best clinicians use drugs to sculpt hemodynamics, not to chase numbers. Ventilation alters preload and afterload. Positive pressure ventilation reduces venous return. PEEP decreases preload but can increase RV afterload. Hyperinflation elevates pulmonary vascular resistance, threatening RV stability. Ventilation, like vasoactive drugs, must be titrated physiologically. The Preload-Afterload master algorithm integrates everything. Identify the dominant force, confirm it with echo, treat it precisely, reassess with VTI and perfusion markers, and correct the underlying physiology, not the numbers. Preload determines filling, afterload governs ejection, mastery requires integrating echo, physiology, and dynamic response. When you match therapy to the correct force, hemodynamics become predictable and shock becomes solvable. This is Pulse&Pressors, reflecting on the marvels of the human body.